Chest drains. If you work in the ICU, you're going to encounter these devices, and on the surface they can feel a bit daunting. Sometimes the terminology is confusing. People talk about oscillation, tidling, bubbling, suctioning, etc. I'm going to try and explain chest drains from physiology through the basic concepts through to the most modern devices that we use. Hopefully at the end of this tutorial you can say that you understand chest drains. The basics of critical care. With me, your host, Pat Nelligan. Chest drains. In this tutorial, I will discuss lung mechanics and pleural pressures, pneumothorax and hemothorax, and chest drain systems. Let's start with a quick look at lung mechanics. Our lungs are located in the thorax, encased in pleura and attached to the chest wall. There's a tendency for the chest wall to spring outwards and a tendency for the lungs to collapse inwards. So you have two counterforces, the outward springing of the chest wall and the inward collapsing of the lungs. Between the two are the parietal and visceral pleura. The result is that there is a slight negative pressure in the pleural space at rest, with greater negativity in the apices of the lungs and lower negativity in the bases. So this is the situation at rest. When the diaphragm descends, the two layers of pleura are dragged apart, increasing the level of negative pressure within the thorax. The lungs expand until the alveolar pressure more or less equals the pressure in the pleura. And at end inspiration, the pleural pressure is more or less at baseline. With elastic recoil of the chest wall and the lungs, the pleural pressure increases above baseline and the lungs empty down to functional residual capacity. And eventually, the pleural pressure returns to baseline. If the pleura is punctured, in this case by a central line or a broken rib, then air enters the defect from the outside. It can also occur from the inside as air passes from atmospheric pressure into the negative pressure space. The lung collapses and blood may fill the hemothorax, leading to positive pressure being trapped inside the chest. The lung cannot expand in this circumstance. At this stage, we have a pneumothorax and a hemothorax, and we're going to place two chest tubes into the patient to drain the material. An apical drain that removes air and a basal drain that removes blood and other liquid. All going well, the gas and the liquid will drain freely into the collection device, and the lungs will re-expand. Now that we understand the basic pathophysiology, it's time to look at the chest drainage devices. You receive a call from the emergency department. Bobby, 22, presents with shortness of breath and a pain on the right side of his chest. He's an asthmatic and he woke up in the middle of the night with this problem. He's brought into the ED and this is his chest x-ray. You will see that he has a right-sided pneumothorax. You can see the lung edge here and no lung markings beyond that point. So this is the problem we have. We have a collapsed lung. A chest drain is a tube inserted from the outside of the chest through the chest wall into the pleural space. This allows air to leave the chest, it allows fluid to leave the chest, and allows the lungs to re-expand. To achieve this, there needs to be a one-way valve that prevents air or fluid from re-entering. These days, chest tubes are usually placed in the mid-axillary line in the fifth intercostal space at the level of the manubrium. We insert a chest drain to remove the air which is causing a pressure problem in the thorax and may actually compress mediastinal structures. So it's inserted here and it allows air to pass outwards. But when the patient takes a breath subsequently, there is now negative pressure in the thorax, and air will go back in. So we need to solve this problem, and we solve this problem by essentially putting the chest drain underwater. And the way this works is very easy to understand if you've ever sucked or blown through a straw. It's very easy to blow air out through a straw into a liquid, and it bubbles, and you can see the air just bubbling up and passing out of the liquid. When you want to suck in, you need to generate a fair amount of pressure within your mouth to get the liquid to move up into your mouth. But you cannot pull air in because the liquid stops the air from going into the straw. And that's how chest tubes work in this setting. The tip of the chest tube is immersed in water 2 centimeters exactly below the water. So when the gas passes out of the lungs, it goes into the water, it bubbles out of the water, and then goes out into the environment. It can do this if the pressure inside the pleura is greater than 2 centimeters of hydrostatic pressure, and that allows the air to leave the chest. When the patient takes a breath in, the negative pressure within the thorax pulls on the water, and that acts as an elegant one-way valve. Now, the key thing you need to understand, of course, is that the chest drain must always be below the level of the chest. Dara, 44, is involved in a car crash. He is T-boned on the right-hand side, and he has significant chest trauma with rib fractures and pneumothorax and hemothorax. The air that is trapped in the inside of his thorax needs to be drained, and the blood that is trapped inside his thorax needs to be drained and the volume measured. We need to insert a chest drain that is immersed in the liquid. And we do this by applying the chest drain and then inserting it into a bottle. And what happens is the gas and the liquid passes into the bottle. The liquid drops to the bottom of the bottle, it will collect and it will increase in size, and then the air will pass through the bottle and outwards. But the key thing to understand here is one bottle is not enough. The drainage bottle cannot be used as an underwater seal because the level changes and the seal must be 2 centimeters of water. What we need is a second bottle with an underwater seal. Air exits the pleural space during exhalation, and the seal prevents the air from returning during inspiration. So now we have our 2 bottles. The first bottle that collects the liquid, the second bottle that acts as a standard underwater seal and allows the air to pass out. This is usually good enough for most pneumothoraces. But what happens if the lung fails to expand? If the lung fails to re-expand, suction must be applied to literally suck the lung back open. So this is what you would think we should have. 2 bottles. The first bottle, that's drainage. The second bottle, that's an underwater seal. And then a suction device that pulls the air through the system. On the surface, this would look reasonable, but this is not a safe thing to do because of the danger that someone will turn that suction up way too high and cause an injury to the patient. So a third bottle is required, and it looks like this. In the third bottle, which is attached to the suction, there is an extra tube running through it. It's a vent tube, and it's inserted to the bottom of the bottle, and then water is put into the bottle up to a certain height. In this example, 20 centimeters of water. And the idea is that this acts as a fail-safe. We've set the suction at minus 20 centimeters of water. And the only way air is going to go through that vent is if the suction exceeds 20 centimeters of water. So let's look how this works. We've set our suction at minus 20 centimeters of water, and we're going to fill up our third bottle to 20 centimeters of water and turn on the suction. Air is drawn from the air-containing part of the bottle into the suction machine and expelled. Now, what happens if someone comes to the bedside and turns the suction up by accident, thinking it's a different type of suction, for example? So in this situation, the suction has been turned up to 30 centimeters of water. Initially, air is drawn from the chest, but because of the third port, the one in the middle, the surplus air above 20 centimeters of water is pulled from the outside. It bubbles through the water, and this maintains the desired 20 centimeters of water suction level in spite of the mistake. So the idea of this is that it adds a level of foolproofness to the system. Now you may say, I have never seen this 3-bottle system. And you probably haven't, because nobody has done it this way for decades. Instead, you'd have seen something like this. To understand this, you need to understand the 3-bottle system. This is a relatively modern chest draining system that incorporates the 3 bottles in one place. This is the first part of the system, and it's the drainage. The chest tube connects to this, and then the drainage runs down from here. Obviously, this whole system must be below the level of the patient for liquid and air to drain out. Sometimes you will see this. This is a 2 or dual drainage system that will connect to 2 chest drains. And you can see that it says collection 1 and collection 2. This is very handy if you've got 2 chest drains attached to a patient that aren't draining a lot of fluid between them. The underwater seal is located here. It is dyed blue so that you can see it, and the chamber needs to be filled using a 20 ml syringe that is attached. The level moves up and down here with tidal ventilation. Here is an example of both drainage and oscillation, which is sometimes called tidling for tidal ventilation. The syringe that fills this is attached here on the top. You kink it and you pour in 20 ml of water. The last chamber on the right is the suction control, and that is filled to the level that you wish to limit suction, -15, -20, or -25. You fill the system up to 15, 20, or 25. The release port is here. It's located on the top. It is where suction is applied, but the suction control is filled in a cap-covered compartment behind this. Let's review how the 3-bottle system works in one product. The first component is passive drainage of blood, serous fluid, or air. Blood drains into the first canister and then into the overflow. This will hold up to 2.5 litres if a single system is used. Air bypasses this and travels to the underwater seal compartment. It passes through and goes out into the atmosphere as long as the positive pressure in the chest propels it out. The fluid will oscillate up and down with breathing, but it should not bubble. If there is a persistent air leak, manifest by bubbling, or the lung fails to expand, then suction is started. We have filled a canister to limit the suction to -20 centimeters of water, and the suction is started. The canister will bubble away continuously, and air is now being pumped directly out of the pleural cavity. If the suction is accidentally increased above -20 centimeters of water, for example, to -30 centimeters of water, nothing will change as the column of water prevents super suctioning. If you want to increase the suction, the canister will need to be filled up to a higher level. In this case, it tops off at -25 centimeters of water. Now, if this fails to work, if there's a persistent air leak and the lung hasn't expanded, well, now we've run out of rope essentially with this system. So we're going to have to connect the suction directly to bottle 2. How do you turn off the third bottle? A red cap is placed over the intake vent and the suction is applied essentially to the second bottle. So this defeats the third bottle completely because air cannot be sucked in to give you that safe parameter. If a patient is requiring this level of suctioning, it's very unlikely that high suctioning will damage the patient's lungs, and usually this type of therapy is performed in a highly proficient intensive care unit. This is a picture of a chest drain at the bedside of a patient. You can see that the suction control cap is on and the patient is not attached to suction. This is a portable suction machine. Now this is all very fiddly, so modern dry suction devices that cost a little bit more are available. This is one such device, and this has a switch that controls the maximum suctioning that can be applied to the patient without the need for a third bottle to be filled with water. Now, a few quick tips about using chest drains. First, continuously check the location. The tubing and the drain must be below the level of the patient or fluid will not drain. Be careful also that someone hasn't picked up the chest drain and put it into the bed beside the patient. For example, if they're going for a CT or an MRI, they can clip onto the side of the bed. Make sure someone hasn't kicked it over or a wheel of the bed hasn't gone across the tubing. Avoid trailing tubing. Two pictures of the same chest drain. On the left, you can see that the tubing is trailing on the floor, and this is incorrect. The tubing should be taut like it is on the right-hand side because fluid needs to float downhill. It has to follow gravity. Otherwise, like in the situation on the left, it has to actually go uphill to get into the drainage device. Don't leave fluid in the tubing. Drain it. This is something I see all the time. It's one of the misnomers that you see in the ICU, that it's okay to have fluid in the tubing because you can see it oscillating back and forth like this. But this is incorrect. Remember, for conventional chest drains, we are draining both fluid and air, and a moderate air leak will not pass through several centimeters of fluid, which acts like a bung. So the fluid needs to be tipped into the drain at regular intervals. Everything that I've talked about so far has been very analog, but we are now in a digital era, and modern chest drainage systems will transition to be fully digital as time goes on. An example, Noel is 64 years old and he undergoes a right upper lobectomy, and he comes back from the operating room with this device attached to him. This is a modern digital system. It's known as the Topaz Plus. It's going to simplify your management of chest drainage well into the future. Let's go through what this thing does. It has a main unit. It has tubing that is attached to the chest drain, and it's a dual tube. One is for drainage, one is for monitoring. It has a display and a drainage bottle. In this case, the drainage bottle will fill up to 800 mils. The stuff that's in the drainage bottle is milky looking. These devices are really easy to use. So what we have is a base unit into which power goes, and onto that clicks the control unit on the right. Two sets of disposables are attached. The first is the tubing that attaches to the patient's chest drain, and the second is the drainage canister that can be 300 mils, 800 mils, or 2 liters. The device is switched on and a self-test is started. The amount of suction is determined and off you go. It's so simple. And on the screen, what we see on the bottom is the amount of negative pressure for suctioning in either centimeters of water or kilopascals. And then on the split screen in the middle, the air leak is determined on the left-hand side, and the amount of fluid that is being drained over 24 hours or so far today and over the last hour is measured. This is a Topaz device attached to a patient just like Noel. Note that the material in the 300 ml drain is mostly blood. If we look at the top of the device, you can see that the tubing attached to the machine is double-barreled. One barrel is for drainage and the other is for pressure monitoring of the tubing. On the screen you can see that the air leak is being measured. The air leak in this case is 70 mils per minute, and if you look very carefully you can see the amount of drainage that's going on. It's 1055 mils so far today and 35 mils in the last hour. If we follow the tubing all the way up to the patient, this is what we will see. This is the patient's chest tube. This is the sample port connector that connects into the chest tube, and this is the double tubing that connects to the Topaz device. Several hours later, you go back to see Noel. You can see that after 20 hours, Noel's digital chest drain is no longer measuring an air leak, and the hourly drainage is only 70 mils. So the chest tube can come out at this point. Digital systems allow for precise measurement of drainage and air leaks and accurate control of suctioning. They're far easier to put together than the standard chest drainage systems. The device prompts the clinician that the lung is fully re-expanded, reducing the duration of chest drainage. There's lower risk, they're easier to use, they're portable, and they are associated with a shorter duration of hospital stay and chest drainage. In terms of guidance for the UK NICE system, the digital system is recommended after pulmonary resection or pneumothorax because it can reduce drainage time and length of stay in the hospital, improve safety for people with chest drains. It also may improve clinical decision making through continuous objective monitoring of air leaks and fluid loss. Thanks for paying attention to this tutorial. I'd also like to thank Laura Burke and Claire Lavelle for answering many of my questions regarding chest drains. Just to review what we've covered in this tutorial, I started off with a discussion about physiology of pleural pressure and tidal ventilation. I then went on to talk about pneumothorax and hemothorax and the 3-bottle system for chest drainage. I discussed the principles of suction and wet versus dry suction, and I finished with a discussion about digital chest drainage systems. I'll see you soon. So that was an introduction to chest drains. I hope you found that useful. If you did, please subscribe at YouTube, follow me at ccmtutorials.org, leave me some likes and some comments. If you have any questions, just post them in the section below. I'll see you soon.